Today I'm going to present a case. It's very interesting case because sometimes it's happened for us to work in the hospital. Here is a 58 years old man. He has abdominal injuries by a marble saw. The machine of injuries is abdominal injuries by a marble saw. The injuries is abdominal wound with 15 centimeters, with aumento comes out through this wound. The pre-hospital, no doctor. Here in Brazil, sometimes we have a pre-hospital who has no doctor, only nurse and the driver. The treatment was in the scene, was only put a bandage of the wall. What to do? If you're going to receiving a patient like this, what to think about? There's information that you have. Valeria?
Dr. Antrach, please, your comment.
Yeah, so a marble saw, I'm not quite sure what it is, although I'm guessing it's probably like a circular stone cutting saw that's handheld and right. And
yes.
And did the blade fracture, or did it was there no guard on it, so it just kicked back and cut into his abdominal wall? So
during his working, the saw run on the abdomen.
Okay, so it didn't fracture like the case I presented. The blade fractured and it flew and sliced through. So right, and then how long before he presented was the injury?
It's about 30 minutes.
Okay, so a recent injury. So, you know, I certainly want to know about his status. So the omentum was poking through, and it sounds like other than the omentum poking through, that otherwise he was okay. He wasn't tachycardic or hypotensive. He was alert, and I assume that was the case. So otherwise, you would have mentioned. So I go ahead and do the full physical examination and get some initial laboratory studies. I'm guessing that it cut through the abdominal wall, and so there is an evisceration. And you know, you need to be concerned, even though it sounds like he didn't, he's not bleeding actively. He may have injured a loop of viscera, and so he needs to undergo a thorough exploration. I would go ahead and do an EFAST exam and look for signs of collection of fluid within Morrison's pouch and in the pelvis, and likely he would need to go to the operating room for an exploration through the midline, most likely. I'm not sure how big the abdominal wound is. It's probably not big enough to explore through, but I would probably, to be safe, do a standard exploration, especially if there was fluid found on ultrasound in Morrison's pouch or in the pelvis or in the spleno-renal pouch.
Thank you, Dr. Antrach. Dr. Hochman, Boston, any other comment?
No, I just did a Google search for marble saw, and it's a circular saw that is handheld. So this patient has evisceration of omentum, and he needs to go to the operating room. I will treat this as a regular stab wound. Evisceration is usually an indication that there is another significant injury. So I would do a primary, secondary chest and pelvic X-rays, or KUV in this case, and after that, probably go straight to the operating room. Thank you.
Thank you, Dr. Hochman. Dr. Supa, Bangkok.
I agree with laparotomy in this patient, and meanwhile we should put the moist clean gauze over the visceral organ and send him to the OR. Thank you.
Perfect. Dr. Santos, any additional comment?
I agree with the other person. I think patients need a laparotomy, but I want to ask to Collet, where is the place where the injury is? The thoracoabdominal is near for the pelvis, because it's very important. because it will make a plan to make this abort.
Okay, I go to show soon. Okay, go to see the patient.
Great.
Okay, we have Dr. Oh, sorry, go ahead.
But laparotomy is indicated in this case. Okay.
Thank you, Dr. Santos. Dr. Valles, I'm not sure. Thank you for joining us today. I'm not sure if you saw the first slide.
No, I missed the initial presentation, but I'm assuming it's a stab wound with evisceration, 15-centimeter wound. So, I mean, I agree with what everyone said, that the patient needs to be in the operating room. My only question is whether you could use this wound, partially close it and do a laparoscopy if the patient's stable versus doing a laparotomy with the wound. I don't know, it depends. I'm not sure. I don't have a picture of where the wound is, so it's hard for me to say. But I mean, if possible, if the patient's hemodynamically stable, maybe you could have laparoscopy and save a big laparotomy.
Thank you, Dr. Valles.
Also, just let you know, I have to leave at 8:30 because I have a conference call, so.
Okay, thank you so much.
All right.
So I think we have all, if anyone else has a comment. No, Dr. Collet.
Okay. Okay. Here is the emergency in the patient. Respiratory rate is 60 EPM. Saturation, oxygen saturation is 100%. Vesicular present bilaterally. Blood pressures are 130 by 109 millimeters of mercury. Cardiac rate is 93. Glasgow Coma score 50. Pupil is isochoric, no photoreagents. Intl. Let's go to see. Here you can see the arriving the patients in the emergency room. You can see what. Sorry, because there sometimes can be my finger in the image. It's not very good pictures, but okay. You go to see the patients arrive. You can see as the pre-hospital. The patient was put on the bed, and then you can see the monitoration, and can see the wound cover dressing by gas pads, and then you can see the wound. Okay. Okay, see the patient's parameters. Okay, I go to stop here. What to do with these patients now? You can go make the patients go to make image exams like ultrasound, fast ultrasound, CT, X-ray, or can put the patients through the surgery immediately.
Okay, Dr. Supa.
I think the classical answer for this is to do the laparotomy via a separate midline incision to check whether or not there is any visceral injury. But alternative to this method is first to try to extend the wound, the right upper quadrant, and try to look for any injury through the Collet incision. And the second thing is, like Dr. Byers mentioned, is to try to close the first wound and do the laparoscopy. But for me, I think we could try to explore his abdomen through the right upper quadrant wound. It looks quite big. Thank you.
Thank you, Dr. Supa. Dr. Byers, any comment now?
I agree with that.
Okay.
I agree with that, yeah.
Perfect. Dr. Hochman, Boston.
Well, I really didn't see the omentum, but I believe if you tell me that there is omentum there, this patient, if you would treat this like a regular stab wound, this patient has a significant chance of having an intra-abdominal injury, which will mandate an exploration. I don't think that you can close that wound in order to achieve a seal for laparoscopy. I don't think laparoscopy will be an option here. My concern with that wound, where the location is that the superficial epigastric artery might be lacerated, and they tend to bleed a lot. So I do not know, without looking at the patient, I'm not sure which approach will be better, either to extend the incision and do like a subcostal incision and explore the abdomen that way, and after that repair everything, or do a separate midline incision. But this patient needs to be explored. I wouldn't do FAS or anything else, because I know there is peritoneal penetration. If I see fluid in the abdomen, doesn't mean anything. And I don't think a CT will help in this case, because this guy needs an exploration no matter what. So it will be OR, and the question about incision will be after examining the wound and when the patient is under anesthesia. Thank you.
Thank you, Dr. Antrach. Any comments?
Yes, so I agree with pretty much all of the comments. And as Dr. Supa said, well, it looks like a pretty big incision. It's 6 inches. It's a relatively big wound, but the abdomen is even bigger. So, you know, I don't really think you could do an adequate exploration without extending the incision, and then it'd be hard to explore the lower abdomen. You know, it depends on if there was a loop of bowel injured, whether you could really adequately explore the whole abdomen through a right subcostal incision. So I would be inclined to make a separate midline incision. As far as the FAST goes, I just think it's part of the physical exam. It's right there in the trauma bay, and you know, if you see a lot of fluid in any of the dependent spaces, and then you haven't found, then you know you need to really look carefully for where the injury is. And it just takes a few seconds, and I just think it's part of the physical exam, like putting your stethoscope on the chest or the heart, or you know. So I just do that as part of the physical exam. But I agree that wouldn't, whether it's positive or negative, you still need to go to the operating room.
Yeah, I think we lost Dr. Antrach. So we can go with Dr. Santos. Dr. Santos.
Okay, I think this patient has a clear indication of laparotomy, but the patient is stable, and I think if you can make studies possible to the patient, like a CT, will help us. What's the better strategy to abort patient? Sometimes we have I have a patient at one time that arrived like him, and he had a cava vein retrohepatic cava vein injury, and we change we change our abortion for this patient. I think this patient has a clear indication of laparotomy, but if I can, I have an exam for this patient. I can make a CT for this patient. This is what I want to say.
Thank you, Dr. Santos. Dr. Mohammed Bawasir, do you have any comment?
Sorry, I missed the first part.
Okay, no.
Later, I apologize. But my understanding, it's a stab wound with peritoneal penetration.
Yeah, it's a marble saw injuries on the abdomen with evisceration, epiplonal evisceration.
With evisceration?
Yes.
Yeah, I would agree with the other comments. Probably an exploratory laparotomy right away.
Perfect. Thank you so much.
Thank you.
Dr. Collet, we go back to you.
I know that's very important, but the thing is very important in this case is the examine the wound. So I take these patients to the OR and make an examination of the wound, because it's very difficult to examine the patient with pain. So, okay, here. In the surgery room, you can see here. the people comes through the wound, and the examination of the wound, you can see it's very big wound and penetration in the wound. No blood comes through the incision. So at this moment, I think it's very important because I have to see what to do with this patient. I can go to a laparotomy or a laparoscopy in this situation. And if I go to laparoscopy, what happened? So I go to show here, this for discussions, all people says, the people, someone can sense how many people can go to a laparoscopy in this patient. Start the procedure with a laparoscopy. Valeria.
Okay. Dr. Santos, what would you do?
I will make a laparotomy.
Thank you. Dr. Byers?
I would do a laparoscopy with the left upper quadrant of support.
Thank you. Dr. Hoffman?
I will go straight for laparotomy. Having said this, the wound is probably not too deep because of the way that the circular saws are. They have and they can penetrate essentially half of the circumference of the saw. So based on that image, this is probably like a 10, 15 centimeter saw, so it didn't go too deep. So it's likely that doesn't have deep injuries. It's most likely just only the abdominal wall. But I would probably go for laparotomy because I think it would be, this guy is very obese, already have blood in there. It would be very easy to miss a minor injury to the colon or the bowel. So I think this guy bought himself a laparotomy. Thank you.
Thank you, Dr. Hoffman. Dr. Supa?
If I plan to do laparoscopy in this patient, I may have to close the skin at least of this wound to make a pneumoperitoneum possible. And I put the port at the inframedical incision, like doing lap chole, and try to look for injury. But in this case, I prefer to extend the wound a little bit more and try to explore for injury through this big wound. Thank you.
Thank you, Dr. Supa. We have Dr. Bawasir.
I would go straight to a laparotomy. I would think it would be very difficult to inflate the abdomen with peritoneal penetration, and in my hands with the laparoscopy, I may miss minor injuries.
Thank you, Dr. Ontrach.
Yeah, so I think for the people that are very skilled at laparoscopy, it's reasonable, but in this case, because of the size of the abdomen and in general, a laparoscopy would only be helpful if you find an injury and it's one that you can fix through the laparoscope. If you explore and you don't find anything, you know, it'd be unless you're absolutely certain you saw every bit of the small bowel and you can rule out a visceral injury, and you know, I think it's a bit risky, but in my case, I would probably go straight for laparotomy.
Thank you, Dr. Ontrach. Dr. Collet, I think those are all the panels.
Okay. I go to show what's happened. Let's go. Here, I decide to start this patient with a laparoscopy. So I close the wound. Here you can see closing the wound. I prefer to close the peritoneum or the aponeurosis, not the skin in this moment. And then, here you can see closing the position of the position. I am here, and you can see the position of the trocars, and then you go to see what's happened. Here you can see, I go to stop in part of it. You can go, you can see here the people through the wound here. I approach with using the wound. And here you can see the small ball. You can see clear there is an injury of the small ball. And can see all the column. Can see, it's possible to see the column. There's no injuries in the column. And so I go to show the injuries. You can see blood. And here you can see one segment with injury of the ball, small ball is the medial portion of the ball. And here you can see another ball with another injury. So we decide in this moment to run all the ball. You can see the injury here. You can identify clear the injury. And at this moment, sometimes you can convert the surgery. So I decide to continue the surgery by the laparoscopy in this moment, and to find the initial portion of the ball and run the ball. Go to see. You can run the ball, you can see both portions of the ball. And to identify the injuries ball portions, one in this portion, about 1 meter of the trice angles, trice ligament, sorry, and continue the injuries, can see a small portion, normal, and another portion with a transection, the wall. And there is continue, can see no more injuries in the ball. In the column, there is no injuries. You can see the second ascendant column, there is no injuries. And at this moment, we think what to do in these patients at this moment. Valeria, what to do? What to think? You convert the surgery, try to repair through the laparoscopy, or something different?
Okay, Dr. Byers.
Okay, my last comment.
Yeah.
Hold on 1 second, Kim. My last comment is I've had cases like this and the wound is very handy. And so basically what I did is I took the bowel up through the wound the patient has already and just repaired the bowel through that and then just dumped it back in. And that's it. Because, you know, I feel confident laparoscopically that I can find the injuries. And so the injuries that you have, since you have a wound like right there, you could just pull it up and fix it, and that's that. But sorry, I have to leave. Good luck with the case. A very interesting case. Thanks.
Thank you, Dr. Byers. Dr. Supa Hancock.
Dr. Byers' idea is very interesting, and it's a possible option. But for Dr. Collet, I think he could easily repair this injury via laparoscopy. Thank you.
Thank you, Dr. Supa. Dr. Santos?
I agree with Dr. Supra. I think if you can make the laparoscopy, you can find injury. If you have experience, you can make the correction by laparoscopy. So it's this.
Thank you, Dr. Santos. Dr. Antrach?
Yes, I agree with Dr. Byers that you know the quickest, most expeditious, most secure way to repair the injuries, but it's well done laparoscopy, and I also agree that Dr. Collet could probably repair the bowel just as easily laparoscopically.
Thank you, Dr. Antrach. Dr. Ahmed, Boston?
Well, I would have started open, so I would have this question. But I like Dr. Bayer's approach. If you have this diagnosed laparoscopically and you already have a big hole in the abdominal wall, probably the easiest and more expeditious approach is to go through, reopen the wound and exteriorize the bowel that way. That would be really a very elegant solution to this problem, because it looked like part of the bowel might need to be resected because it's more than 50% of the circumference, although I'm not sure looking at the video. Thank you.
Thank you, Doctor. Dr. Bawasir?
I would probably have converted to an open and do a primary repair or resection anastomosis, hands-on, or yeah.
Thank you, Dr. Bawasir. Anyone else a comment? Dr. Collet, we go back to you.
I agree with all comments, and I agree with Dr. Byers. I make this. Let's go to continue. Here, I put the ball through the incision. You can see. Maybe resection the ball at the moment. I prefer to resection because there is some areas, maybe some ischemic or maybe damage because the seal, and make a resection. Then I put again the ball into the abdomen and wash the abdominal cavity with saline and aspiration. You can see this name is video assist surgery, and very interesting procedure, maybe safe and easy to do. Okay, let's go. Here is the patient, the incision, the punctions of the laparoscopy, and can see we avoid the laparotomy. You can remember that we make laparotomy in this case is the traditional incision. Some things, very important things, is the hernia or evisceration that this patient maybe happen in this patient. So using the laparoscopy in this approach is very interesting for this case. The patients have an eventual evolution and discharge on the 5th post-operative day. Final comments, please.
Thank you, Dr. Collet. Dr. Hochman, Boston.
I have nothing but congratulations for Dr. Collet, like always, a master of surgery, and we're here to learn from him. Thank you, Dr. Collet.
Thank you.
Thank you, Dr. Hochman. Dr. Supa, Hancock.
Thank you, Dr. Collet, for presenting this case to us. Wonderful management. And as always, I learned a lot from you.
Thank you, Dr. Supa. Dr. Santos, Brasilia.
I think this is a great case that showed to us that laparoscopy is a reality for us. Okay, it's a great case. I like too much, and I try to make this in my experience. Okay, thanks for us.
Thank you, Dr. Santos. Dr. Andrach, Amsterdam.
Yeah, so very well done, very nice case, and also I think it shows the value of conferences like this one, where people with good ideas can disseminate them among the attendees. So we all learn something, and that helps our patients.
Thank you, Dr. Andrach. Dr. Bawasir. I'm sorry, Dr. Bawasir, where are you joining us from?
I'm from Boston.
Oh, okay.
Yes. I work with Dr. Hartman.
Yes,
He's my boss.
Thank you. Sorry.
Yeah. So he has to agree with me, otherwise he gets into trouble. No, I'm not joking. Okay.
Thank you, Dr. Collet, for sharing this case. I really like this idea of doing extracorporeal repair through the stab wound itself. and I learned a lot, and this is a new technique for me, and I'm definitely going to try it next time. Thank you.
Thank you, Dr. Babas here. I think we have all. I also, Dr. Martos, are you there? You go.
Yes. So, Francisco, thank you very much for presenting this case. Dr. Collet, another great case. That's the idea of these meetings, to show an interesting case, and have a different approach, a lot of discussions. And again, you have the ability to do this laparoscopy initially, and then did this repair. A lot of people would just do explorative laparotomy. That would be fine also. But the idea is to show the residents, the fellows, the graduate students, that sometimes there are multiple ways to achieve the same goal, that's to treat well the patient. Just remember, this is a meeting up from Panamerican Society. In a few months, we're going to have a new platform. All these lectures, all these videos are going to be available on the platform. And I would stimulate everybody to join the society. And Dr. Collet is the chair of the telemedicine committee. A lot of activities are going to be happening in the future, so be ready for in 3 months to have like a brand new platform. A lot of knowledge, a lot of lectures, a lot of discussions will happen through this platform. Dr. Collet, thank you very much. Dr. Supa, looking forward for another presentation from you. And please, all of you, contact Valeria to schedule a presentation in the next few weeks. Thank you very much.
Thank you, Dr. Martos. Dr. Collet, I'm not sure if you have any additional comments. Thank you very much for your presentation.
No more comments. I thank you for the comments, and I believe that laparoscopy may be saved for some cases in the trauma, but not for all patients, and not for all places. You have to have special training, and you have to have the adequate equipments to do this. So I believe that laparoscopy is one important procedures in trauma, but maybe some cares on the use there. Thank you.
Yeah, Francisco, I agree with you. So sometimes in the past, when you have a small wound, right, you do a wound exploration. I don't like wound exploration, no. Even when you do a laparoscopy, when the trocar come out, sometimes it's very hard to go through the peritoneum again through the same way. So I think laparoscopy for initial approach to see if this penetrate the peritoneum, the abdomen or not, and then to see if there's any obvious injury. But if you penetrate it, if you're not safe, you can start laparoscopy. Then you save ELAP for a patient that didn't penetrate the abdominal cavity. But then some people will be safe to feel safe and feel okay to run the bowel. But if you're not, you can start laparoscopy, then open and then run the bowel and see to be 100% sure that there's no injury. So depending on the level of the skill, depending on the level of the equipment that you have in your place, but if you do the traditional way, like ELAP is correct also. So, but it was very important to raise the options and then to discuss all the options. Thank you again for another good case.
Thank you very much, everyone, for joining, and we hope to see you next week. Have a good day.